All right, so thank you everyone. It's a pleasure to have you all on. Allow me to quickly do a quick round of introductions, even as we welcome you to this webinar. And I will then, we'll quickly then run through the agenda and just get started. So let me start off by introducing myself, and then I'll ask the rest of my panelists to kindly introduce themselves. I'm Kim Kariuki. I'm an engagement director at Busara, and it's exciting to be hosting this webinar with Basic Needs and WASI, and also with the Ministry of Health. So let me quickly allow WASI and Basic Needs to introduce themselves, and then we'll introduce our key speakers. So Rosemary, would you like to go ahead?
Thank you, Kim. We're very pleased to finally have this happen. It will be very interesting to hear the opportunities and gaps in mental health during this period. So my name is Rosemary Gadara. I'm the Executive Director at Basic Needs, Basic Rights Kenya, and welcome everybody.
Great, thank you, Rosemary. Alex, would you like to go?
Hi, everyone. Again, thank you for the introduction there. I'm Alex and I run WASI, which is a digital mental health company. And we connect people with therapy and therapy services over their phones across Kenya and East Africa. We're really excited about this conversation.
Great, thank you, Alex. All right, so from the Ministry of Health and the country government more broadly, perhaps we could start off with Stella and then go on to Jacinta.
Okay, then let me go. Hi, everyone. My name is Stella. I work in Nairobi County. Now we are being called Nairobi Metropolitan Services. And I coordinate the mental health services in the county. And I'm glad to be here to be able to share.
All right, thank you. Jacinta, please go ahead.
Thank you, Kim Kariuki, and good morning, everyone. My name is Jacinta Mwende from the Department for Social Development, State Department for Social Protection, Ministry of Labor and Social Protection. Thank you so much for inviting us for this webinar meeting. Looking forward to, thank you very much. Over to you.
Thank you so much, Jacinta. It's a pleasure. We'll be hearing from both Jacinta and Stella in a little while. All right, so great. Thank you so much, everyone. Again, it's a pleasure to host you all on this webinar. To get us going, we've designed a few polls. So I'm going to launch a poll now. I'll be happy if you would take 3 seconds. It's just one question. And I'd love to get your answers to these questions. So here goes the poll. All right, I'm hoping you've been able to record your responses. I will just quickly end the poll and see what we get. So ending in 5, 4, 3, 2, 1. All right, so let me end poll and see what we have. So that's what we got. So it says that nobody voted. So I guess something went wrong. So let me resume that poll.
Kim, it actually brought some results when you showed that.
Oh, it
what
did,
you just showed and yes.
Ah, okay, cool. So maybe then, let me see, sharing results. It's still showing 0% on my side. Maybe it's still tabulating.
No, on my side, it shows 9% no negative impact, 73% minor negative impact, 14% yes, major negative impact, and 5% do not know.
Oh, interesting. Interesting. Okay, great. No, thank you for that, Rosemary. I guess there's a bit of a delay between your screen and mine. All right, so one other quick poll, just so that we get the polling out of the way and then we can be discussing the results. Give me 1 second. All right, so one thing we'd love to know is who's on this poll or who's on this webinar. So I'm gonna launch a webinar with 2 questions. I'm gonna poll with 2 questions. Please answer to the extent to which you feel comfortable. Again, we'll take a very short time just to get a sense of who's on this call. And it is live. Right, so the first question is, which statement or which category best characterizes your occupation at this time? And then the second question is on what context do you feel like you're most familiar with, low-income country or higher-income country? All right, so going to end the poll. Hopefully you've all gotten a chance to quickly respond. Counting off in 5, 4, 3, 2, 1, ending. Great, so let me click on share results. Rosemary, you may have to read it out. I don't see it on my side, but I'll try and include it in the presentation as we go along.
Okay, the results say that we have 9% students, we have nobody from the academia, we have 32% researchers or consultants, 36% implementer, that's NGOs, and 5% funders. Then non-medical professional, 5%, government 5%, and 20%.
Which one was that last one? Other 15%?
23%.
23%. All right, great. Great. Thank you so much, everyone. I really appreciate your insights. And thank you for completing the webinar. The polls. All right, so quickly moving on, we thought how we'll structure this for today is to have an open conversation around the opportunity, the gaps around mental health programming. So we've done the quick survey and introductions. So that's done and dusted. What we'll move on to quickly is the background. So to lay a bit of the stage in terms of what's going on in the developing and in the developed world, and then allow Stella and Jacinta to give us their perspectives from Nairobi Metropolitan and from the Ministry of Labor and Social Protection. Thereafter, we'll be open for questions, and then we'll end hopefully on time at 12:30. So without there being much of a further agenda, I'm happy to move on unless someone has a question or comment.
Yes, kindly change its county mental health, not medical health. Kindly.
Yes,
because that's a whole different. Okay.
Yes, sorry for that. We'll make a quick change. Alrighty, great. So thank you so much. We'll quickly jump into the background now. So the results that we read off from Rosemary were quite interesting. Thank you everyone for completing that poll. We found some data that I was asking people in the US similar questions. So trying to understand how is COVID-19 affecting individuals. And interestingly enough, so between March 25th and 30th, the majority of the people felt like there was no negative impact. So that's 2/3 of the population, and about 1/3 of the population felt that yes, there's an impact, but it's relatively minor. So that's fairly interesting because, in the US at that time, cases were beginning to soar. People were more or less going home and being told to stay indoors, and social distancing was just beginning to pick up. But it goes to show that it's not easy necessarily to try and understand or to come to grips with what how quickly a crisis can change, and it can be difficult to anticipate how people are going to be affected. But nonetheless, women seem to be more affected than men. And in the UK, about 34% of people worried about their mental health well-being because of COVID-19. But of course, this was also very early in the developing world. I believe Kenya only had its first confirmed case on March 13th. So by that point, everyone was quickly trying to come up with a plan, a strategy, an approach to handling COVID. So not surprisingly that by that point, there wasn't much data. But I think slowly data is beginning to generate, but perhaps not as fast as it could. So just wanted to share that as a bit of context. And then in this next slide, we thought it might be useful to talk about some of the emerging mental health challenges, both from the low and middle income country perspective and from the developed countries. So this is by no means exhaustive, but just top of mind things that are coming up as we've had conversations, and really happy that there are representatives from the county and national government who can give us a bit more of an insight of what's going on in their respective jurisdictions. So the first challenge is on this issue of unemployment rates and social isolation. So not surprisingly, in Kenya and in other parts of the world, social distancing measures were put into place. Intriguingly, in developed countries, the big issue was really about this issue of social isolation. So people now could no longer use the train, could no longer fly. And we began to see a lot of people filing for unemployment benefits and the like. But in the developing countries, the bigger issue tended to be this issue of unemployment. So even till now, we're grappling with, how to better support folks who are either being laid off or have been laid off, and largely the informal segment who have to work or have to go to work every day to earn an income. And on all of this, you can imagine, is beginning to place pressure on people's mental well-being. So the second challenge that we sort of seen is certain populations are more vulnerable. So in the developed countries, it tended to be folks who are incarcerated and people with mental health diseases. There was a case in the media fairly recently of youth who are committing suicide due to isolation and lockdowns. And on that second point of youth committing suicide, we've also seen similar things happening in this part of the world as well. So in the developing world, the youth are particularly at risk. One, because it seems like it's harder for them to adhere, but then they tend to be more susceptible to negative thoughts at this time. And as well, the fact that COVID-19 has compromised sort of our way of life in this season means that even the informal workers and bereaved persons are experiencing, are particularly exposed. So on a personal note, we lost a relative this past week, and it was just a challenge not only to grieve, but even to think about planning and subsequent support for the family because of all the restrictions in place. So on challenges, and of course that in the issue of bereaved persons is similar as well in the developed world, where folks can't actually have burial states, especially for those who've passed away from COVID-19 in places like Italy and others, where we've been seeing in the media where the medical health services personnel come in, collect the remains of the individual and take them for burial, and in a fairly impersonal and distant manner. So the third challenge is on this issue of reduced access to mental health services. So in the developed world, where I suppose access would be a little bit better than ours, facilities are closed because of social distancing. So it means that even if the help was available, you can't quite get to it. And then the issue of insurance and lack thereof to be able to offset the costs. On our side, and I'm sure Jacinta and Stella will do this piece justice, is the issue of lack of access due to insufficient numbers of mental health workers. There's a gap between rural and urban areas. And something we're beginning to see is this idea of customs. So people believe that there could be alternative methods to either coping with the crisis, getting healed or cured from the crisis. And so that could also detract slightly from people being able to access services. And that's also not to mention or even talk about stigma, which will come to towards the end. The third last point is this issue of pressured health workers. So, we've been seeing in the developed world instances where medical health practitioners are saying it's overwhelming, right? If you have 1,000 deaths per day, and maybe some of those are in particular counties, particular boroughs, it can be quite heavy. And the risk is that burnout is soon to follow. So, the developed countries, they're trying to take time to sensitize mental health providers and healthcare practitioners to access services. But of course, there's lack of time to train and to engage these because of the crisis. And on our end, perhaps the issue of lack of access is a barrier, but it's probably it's probably a ticking time bomb, given that as our cases begin to ramp up, as our facilities and practitioners get overwhelmed, there'll likely be increased demand that might outstrip supply. So there's as well the issue of post-traumatic stress disorder, so PTSD, for COVID-19 patients and their relatives. We can't take for granted that, this disease is new, so there's a lot of fear, it's, killing people. So there's a lot of psychosocial support required just beyond hospitalization. And, whereas they may have those tools to detect that in the developed world, it's unclear whether in the developing countries, there's sufficient diagnostic tools and processes. Lastly, on stigma. So in the developing world, we've definitely seen instances where, and the Ministry of Health has talked about instances where individuals are being stigmatized because of either having experienced or recovered from COVID-19 or having family members who have COVID-19. And so because of that, that could complicate issues, could make it harder for folks to access services, could make it harder for people to want to disclose that they're sick. and that could cause undue tension and frustrate our public health efforts. In the developed world, we've seen instances where there's increased social tension, people are writing threatening letters, there's property being damaged, even as people try to come to cope and come to terms with the magnitude of the crisis and try to find ways to cope. So, in spite of all that gloom and doom, I think it's important to mention that, there are solutions, and it's even more important to find out how to customize those solutions to the local context. So there's great potential for the use of digital technologies and social media, and folks like Wazi are leading the way on that. And in addition, for populations where access might be a problem, or the individuals may be less able to use technology, like the elderly and the low income, there's need to be able to innovate and think through how else can we provide those services to these vulnerable populations. And all of these are looking at structural barriers. Certainly there are some behavioral barriers that we've talked about, this issue of stigma, the issue of people fearing that they may be locked out, they may be looked at in a negative light. We really do need a holistic approach to diagnose and improve access and usage of mental health support services. So there are two, in fact, at least on the technology side, if we look at that, there have been some media campaigns that have been run to help prevent or to de-escalate or diffuse the stigma that's coming out. Telemedicine, so in New York State, there's been a free mental health hotline that's been initiated, and regular phone checkups to help in other markets as well, to help with making sure that people are connected and people can access support. There are applications now that will help you make sure you're a bit more mindful and help you ensure that if you're in a place where you're getting depressed or beginning to feel out of sorts, you get the support that you require. And as well as online activities being organized by in a regular way, so that people can congregate and access the support that they need. In terms of proximity, there's an opportunity to train for frontline healthcare workers. And there's an example there listed of a project in the US. But of course, would love to hear if there are similar approaches and innovations that are happening either at a county or national level that we could take advantage of. As well, training non-traditional groups to provide psychosocial or psychological first aid, given that it's a scenario now where if you don't have access to your typical health providers, there's an opportunity to access the same quality of care through non-traditional approaches. So could be an idea, could be something that we think about. And as well, an idea for consideration, as long as perhaps people can maintain social distancing, is the notion of street mental health care workers. So potentially, even as the government ramps up its national hygiene strategy, potentially there could be ways to dovetail and leverage the support of some of those county health workers to provide much needed mental health services. All right, so let me pause here and allow Stella to talk through her presentation. Stella, over to you.
Thank you so much. And I'm hoping, because from your presentation, I've seen that most of what we are grappling with or what we had, it has been well captured. But since you had asked me to even look at mental health structures at the county level before COVID, during COVID, and even what we're looking forward after COVID, I'm waiting for your screen to load.
Sorry, yeah, I'm not sure what's going on.
Just to take you through.
Yeah, go ahead.
Just to look how our mental health, how our mental health services and structures before COVID, where were we? And how has COVID affected or negatively, and what can we learn from COVID, and what are we anticipating post-COVID, either to make us better, lesson learned, and what we can do. Still waiting.
Right, it should be going now.
So first is So first is just to look at what are the mental health program goals and focus area. You find that as a county, our goal for the mental health unit, just to say that the unit is about, it was established last year in June, around May, June, hived off from NCD program because they realized that mental health is such a big challenge at the county level, and even it happened at the national level. We need to give it focus, and for us to be able as a county to give it prominence, the leadership realized that it has to form it as a unit, and that's when I was given to spearhead the leadership. So the goal is to improve access to integrated mental health services at the primary health care in Nairobi County, because you realize when you look at how health is structured at not just at the county level but even as a country, at the lower tier, what we call at the community, there are so many people seeking help. So we have the community level, and then we have the primary healthcare, and the primary healthcare composed of the community, dispensary, and health centers, and level 3 facilities. So if we have these people who are accessing at the facility, at the community level, where we are training our community health volunteers how to offer psychological first aid, how to detect, how to do screening, we're able to improve this access. And then when they have cases at the community level, they're able to accelerate them and connect them to the health facilities where they are attached. So that is what we are aiming to do, so that every at the primary healthcare level, we have deeply rooted mental health services. So our focus area is to integrating mental health services at the primary healthcare, and we felt that if you're able to achieve this, that when you walk into a health facility with a cough, with fatigue, the healthcare provider, whether it's a clinical officer, whether it's a nurse, is able to quickly ask you mental health questions, quick screening. Have you been sleeping enough? Do you feel off in the last few days? And that one will come again in terms of screening tools, because that is one of the challenge. So we feel that that is going to be a very big win for us. Then another focus area is to improve treatment gap by implementing the mental health MH gap. And if you're aware what it speaks about, because it's a WHO tool, it shows that 80% of the clients don't have access to treatment to mental health. Why? Because number one, they don't know, because there's no diagnosis, or the services are not available. And I'm sure maybe all participants here would attest that mental health practitioners are very few, even in Nairobi. And people say they are concentrated in Nairobi. For Nairobi County, working for the county, we only have one psychiatrist, serving a population of, we were told the last time, about 4.7 million. And you can imagine, because how much is it to see a psychiatrist? It's about 4,000 consultations. So how many of our population can afford to see a psychiatrist? Very few. So the population don't have access to a psychiatrist. And that is why we are saying we need to reduce that treatment gap and be able to train non-specialists, because in Nairobi, when I talk about specialists, we have one psychiatrist, about 4 clinical officer psychiatrists and mental health, and about 10 or so psychiatric nurses, and we are about 5 psychologists. So there's a very big gap, and we can only ensure that people have visiting primary health care get treatment for mental health, get their refills, get their screening, get their follow-up by training non-specialists, that nurse who is working at the outpatient, that nurse who is working at the antenatal clinic, that nurse who is working at the paternity, that nurse who is a midwife, is able to address issues of maternal mental health. When he's at the outpatient, she's able to ask that patient who is coming in at the clinic or even at the outpatient to seek treatment for other things for mental health. And if a patient or a client is diagnosed to have mental health, they can be follow-up. And with this, we're able to provide psychotropics. So the other area is to improve mental wellness of our clients by enhancing the preventive and promotive mechanism through the leveraging of the community strategy model. One thing I would pride myself working for Nairobi County is that we have a very strong community strategy model. And even as we speak, I'm seated with the community volunteers in a training, because we are training them on COVID and mental health and psychosocial support in the context of COVID. So you can see that because our community strategy is very deep rooted, is very well structured, when we are able to use it to drive the agenda of preventive and promotive mental health, we are able to have a very strong community mental health program. Then the other focus area is availability of psychotropics at the county health facilities. You know that there's a big challenge of accessing psychotropics, and when they're there, they're very expensive. So for us, when we're able to do 1, 2, and 3, and say we're able to prove that we have someone who can prescribe and who is authorized to prescribe, ability to push for those psychotropics to able to move for us. We have ordering system from KESA and be available at the primary health care level, so that that client who is being seen at facility at a health center is able to be seen, is able to go through psychosocial support, and is able to get medication if they need psychotherapy. Sorry, if they need treatment. So what has been our strengths? One is our strength is support from leadership with good governance structures that we operate in. I would proudly say that I have a lot of support from the leadership, and I've been getting a lot of support, and now leaders are cognizant of what mental health, and everyone is looking and learning and saying, Stella, what can we do? What can we do differently? And I get to be looped in all programs. I support HIV program, I support the youth program, I support the sexual and gender-based program, I support the maternal mental health, and I can say that we have I've really started putting pieces together for our mental health program, and so there's a very good support. Rating with a place where there are structures is one of our strengths. Number 2 is that we have mental health policies and guidelines, though not well disseminated. We can ride on them and use them to propel. What are the opportunities? I would say one of the opportunity is the community strategy that is very strong. So if we seek support and moving forward, we are able to ride and make sure that at the community level, we have well-structured community mental health and every other, because maybe just to give you a brief, we have what we call the community healthcare volunteers, CHVs, the community health volunteers are structured into units. So we have units in every community and they man household. So we are talking about a community health volunteer, if well trained on mental health, they're able even to do detection at the with the minor issue of mental health. Because I believe when you go to the community, they know about family planning, they know about HIV, they know about screening for TB. Can we use the same channels to drive the message of mental health? So that is one of the opportunity we have. Then in Nairobi, we are in an urban area where we have access to technology, and we have seen, and it's a lesson learned from COVID, leveraging on technology to pass information, to do screening, and from the surveys that have been done to access of mobile and internet, Nairobi, we are scoring well, and we can leverage on that to pass the message. Then another opportunity is popularization of telecounseling during the COVID. We have learned that with COVID, we are minimizing physical, and we have developed or even accepted as a country and even world over to do telecounseling. I would tell you that before this, it was not very popular and people used to look at it like it's just, but now we have seen counselors, psychologists, and people accepting that you can call and get therapy. So if we leverage on that, and even post-COVID, still utilize their tropics. A patient doesn't have to travel very far to come and get a review by the psychologist for therapy. So we are looking at building structures where even going forward past COVID, these therapies, instead of coming and they're lining up with a very lean staff, they can get they can schedule their sessions, and they can get them either through Zoom, using the technology. Then the other one is the development of mental health IEC materials. Before these, we never had much about mental health. It was just in books and policies. But now we have seen that with COVID, people have developed IEC materials about mental health. Simple things, what we talk about: physical exercise, drinking water, deep breathing. And we are looking at this as an opportunity going forward after COVID, where we are able to develop key IEC materials. Because I'll tell you, I've been talking to partners, and Rosemary can be a witness. I look forward to where when a client goes or a patient goes to an outpatient in a health center, because I have a very, I don't know, because I come from the clinical part, I have a very strong belief that for you to win anything, it has to be well grounded at the primary health care level, because that is where we have a very high number of clients going. So this client, as they are going in because they have a fever, because they, for any ailment, they are waiting at the reception, they are waiting for their triage. There's that poster about mental health, asking them, are you sleeping too much? Are you exercising? The same way we go to a patient and there are posters about PrEP, there are posters about TB, are you coughing? I think we can leverage on that and develop mental health posters that can be everywhere. We develop mental health apps that people are able to do triage on their own. Next slide, please. So what have been our challenges before, during, and before Corona, and even during Corona? Because those challenges we had have just been made worse by the COVID-19. One is lack of standardized screening tools. You believe as a mental health practitioner, we need to have tools. We need to screen for depression. We need to screen for anxiety, postpartum depression. All the mental health illnesses. But do we have standardized tool that when you go to health center A or county A, you go to the next one, all of us are using the same tool to screen for depression, same interpretation. So this is a big challenge. And even now, like yesterday, I had a meeting with my team that are working at the quarantine, and we were, with the help of University of Nairobi, we are hoping to adapt a tool that is able to give us clients coming in for depression, at the quarantine, we are able to do a quick test for depression and anxiety. However, is it a standard everywhere? All counties having quarantine sites, is it standard? I think that's a big challenge. And even going forward after COVID, and I think it's a discussion we need to have top from the ministry, because ministry are the one vested with doing policy. We need to have standardized tool. The next one is data. I don't know who said work not documented was never done. So you find that up to date, we don't have a lot of our conditions, mental health conditions, being captured at DHIS. DHIS is, with that, organization uses the data to do planning and budgetary allocations and all that. So when we find that this data is not well segregated, in that we are able to, as a county, we had, so it becomes a challenge, or even like, I want to lobby for employment of more psychiatrists, but we don't have a very strong data to show what is our mental health state. Yes, studies have been done or surveys, and Nairobi, we scored the highest. But I will tell you why we were showing the highest is because that is where we have the psychiatrist and mental health practitioner. So people from far and wide come to Nairobi, but it's still a big challenge. That is high stigma and discrimination around mental health. And this is happening, as Kim has done a presentation now with COVID, there's a lot of stigma. A client who has a mental health from the community level, we brand them differently from our culture. Every culture has the way they treat their person with a mental health. And worse is, being Africans, we have a very strong belief of being bewitched. It's a curse. So it really hinders people from seeking help. I would challenge you to look at last week's Sunday Nation. There was a story of a guy from Kilifi who has had mental disorder, I think schizo, for about 20 years or so. And that was just one in hundreds or thousands of what people go through at the community level. When you start behaving abnormally, you're seen as an outcast, and they don't think of seeking medical help for you. And the first thing they want to go is to a witch doctor. So that's a challenge, and we really need support, especially from the NGOs who are coming in, activists, for the county, and from the partners. Most of the partners had not budgeted or don't have a budget line for mental health, addressing mental health and psychosocial support. For example, and I've had these, one of the partners do youth sexual and reproductive health for the youth. And I was challenging them. Yes, it's very good. We are checking on that. Reproductive mental health. And we understand the youth are in their formative years and they are more prone to mental health. They are more prone to having mental illnesses at an early stage. So we really need to focus on that. The other one is few mental health practitioners. We don't have enough, and that is why we want to build on rolling out MHCAP. Then is high cost of rehabilitation or inpatient management. You find that as a country, one of our free facility has been associated with a lot of stigma. And if you go for any private, they're very expensive. So I think it's a debate, and I would maybe request, sometimes when you're working for the government, you're not able to make such noise. It can only come from the partners and or activists to say, can we have subsidize costs for rehabilitation? Then there's a lack of synergy among stakeholders, where you find one stakeholder is doing this component that is not in line with what as a county we are planning, or it is antagonizing what other stakeholders is doing. So we feel that as much as we have started, and I've tried to address that by having a mental health technical working group that includes, I bring together all stakeholders in the mental health space in Nairobi so that we can synergize our activities. And then again, because we know Nairobi has a lot of high informal settlement, we don't all go into one informal settlement and leave the others. So post-COVID, what are we looking at? One is that we are looking at a population, a very large population that is going to be left traumatized, yet little support for that, or they will remain undiagnosed because we have few tools to do that and few practitioners to do that. Then is ability to sustain the efforts or activities for mental health and psychosocial support post-COVID. Now everyone is hyped, and there's a lot of response reactions to COVID. But are we going to sustain it in having those messages coming in, having these meetings, and you can bear me witness, where we can still have these meetings discussing, even the same meetings we're having, discussing issues of mental health within our community. I think that is it. And maybe over back to you, Kim, and any reactions.
Thank you so much, Stella. That was a very insightful presentation, and would love to sort of dig into that a little bit more. Allow me to allow Jacinta to present, and then we can take questions from the panelists and from the audience all together, if that's okay. All right. Jacinta, if you're on, please go ahead with your presentation.
Thank you very much, Kim. And thank you, Stella, for that very good presentation of opportunities and gaps in Nairobi County. I've taken note of a lot of things that you have shared, which are very similar, and I commend what you're doing in Nairobi County. I don't know whether, Kim, you've been able to put, you can be able to put up the presentation from my end?
Yes, go ahead.
As you do so, I'm seeing there's a very good question. I don't know whether it is going to be answered after the presentation. Very interesting question there. Is health still under the county government or the national government?
Where is it? I can't.
I saw it on the chat, Stella.
Oh, I didn't see. I'm not able. I didn't see, and I'm seeing in other chats. So we are not under county government. We are under Nairobi Metropolitan Services. I hope I've answered it.
We should be good to go, and thank you for clarifying that question. I think we should be good to go with the presentation.
Yes, thank you, Kim. I'm going to summarize this presentation into just what we are currently doing as a Department for Social Development. As you're aware, we fall under the Ministry of Social Protection, and we've always been involved with welfare of the family, children, women, older persons, and other vulnerable groups. And our main objective as a department is to mobilize and empower individuals, families, groups, and communities to facilitate the process of social change for growth and improved livelihoods. Our vision is empowered families and communities for sustainable socioeconomic development. The department's mission is to build capacities and enhance protection of individuals, families, and communities for improved livelihoods. The mandate of the department is derived from the Executive Order number 1 of 2018 which includes the development and implementation of policies and programs for families and communities in the realization of all the programs and policies that we have for families and communities. So I would say that the Department of Social Development, we have structures in place around the country. In all the sub-counties, we have social development officers at the county and sub-county level who work with community structures to offer services within our mandate to families, to communities. And when we talk about families, we are talking about the older persons, we are talking about persons with disabilities, we are talking about women, we are talking about the youth, and we are talking about children. I was listening to the presentation, which I really appreciate, by Stella, about the challenges which are there. And one of the challenges that has really caught my attention is the law. How has she put it? It is the lack of personnel, lack of, like she's talked about one psychiatrist, and she's talked about the strength, which is a community community strategy model of working with existing structures within the community, so that mental health services can reach the targeted. So in summary, about opportunities for mental health in this presentation is that we are the people responsible to implement the government cash transfer programs to older persons, persons with severe disability, and orphaned and vulnerable children. And we do it through the existing structure that I've just highlighted. And within this structure, like I've just given the latest payment that the ministry has done of about 377 older persons who have benefited from the government cash transfer to older persons. And that has been done. And how people, of course, aware is that one of the challenge with COVID is the lack of, the lack of income, to just provide the basics. So these older persons, when they're able to put food on their table, that reduces, stress for them as elderly people. They're able to observe those, those hygienic standards we are talking about, because they can be able to, to just afford to buy some soap, afford those basics of life, which is good for their health, physical and mental. And we have policies in place, like we have the National Policy on Community Development, which has the overall goal of providing that coordination framework to implement and manage community development practice at the sub-county and county levels. So the social development officers, they are able to, they're guided on how to undertake mobilization of communities for socioeconomic empowerment. We also have the draft community groups and registration bill, whose purpose is to provide a regulatory framework for the mobilization, registration, coordination, and regulation of community groups. Other policies that the department has developed include the disability policy. We have the volunteerism policy, and we also have the social protection policy. And all these policies help us, to define our space in social protection to communities and families. Kim, you can maybe just move to the next slide.
Yep, I think you should be good to go now.
Well, yeah, we also have the National Disability Mainstreaming Strategy, and the goal of this strategy is actually to implement, to guide the implementation of the programs with severe disability in Kenya. It provides, that platform for government and other stakeholders to do that. And we have the Community Development Training Manual for the practitioners on the ground. And we also have the National Standards and Guidelines on Establishment and Management of Institutions for Older Persons. This was launched in 2018, and it's there to, provide guidance on how our institutions for older persons are supposed to be managed in the best interest of the elderly who live there. So the opportunities social development is presenting to us this morning and to the country is that we are ready to partner with all relevant stakeholders, because we have the structure in place to reach families, to reach the elderly with whatever services on mental health that they need to provide, so that we can be able to deliver that. And I would want to say that talking about sustainability of our services during this season of the pandemic and even after, it's a challenge to all of us as a nation to be how best we are going to coordinate and work together, because the structures are there and we put our synergies together, we are going to be able to deliver. So to sustain, one of the biggest opportunity we have, generally speaking, is working together. Like if I can give example of Nairobi County, I would want us to see a situation where going forward, we are going to link up with Nairobi County, Stella's department, and this model can be expanded to have the Ministry of Health, to have us in it, to have Children's Department in it, and have all relevant stakeholders working to deliver the services we want to deliver on mental health. So what is being done to address mental health services by the ministry? One of them that I've highlighted is cushioning the elderly. And recently we are all aware that the head of state allocated an additional 10 billion to cushion the elderly and the orphans and vulnerable households, including widows, widowers, and Vale and Kilifi. And the amount is being paid to beneficiaries. It's about 1,000, 2,000 weekly, every week, months. And we look forward to have it being expanded to the other counties. And then field officers in the Department of Social Development program platforms to communicate this. We really appreciate the key messages which have been developed by us for practitioners, for children's charitable institutions, for caregivers, and for parents and for children, child-friendly messages which have developed, and we are using the same existing structure to share out to the beneficiary welfare committees who are in charge of older persons, to share out with the children's officers, and to share out with the community structures that we work with, like the sub-county social development committees, who represent groups and are working together with our social development officers at the county level. We appreciate the mental health messages that we have gotten on community development, social messaging on how best, and I appreciate one that it has even been translated in the a few different languages, so that it can go to, it can really it can impact when it's translated in Sheng for the young people and the cartoons for children. So we are using these structures that we have to empower our families, to empower our youth on how best they can handle their mental health and handle the situation, the pandemic we are in, where they are. So we really appreciate that a lot, and we look forward to really partnering more with everyone in whatever they are doing, because they're targeting the very families and communities that we are serving. So I've given out those the volunteer counselors here. This is another social support system social development has put in place. Presently, we have 1,110 lay volunteer counselors across the county, and these are retired teachers, retired nurses, retired even civil servants who are volunteered, to offer their experience by working with us. We already have, a manual for them and how we recruit them. And these are the people I want to believe Kina Stella would actually consider working closely to train them, because what we need is to empower them with skills, capacity, build them so that they can be able to be more effective in offering services, psychosocial support to families and to the communities. So that's another structure that is a great opportunity, and that the ministry is right now. We are able to serve the communities. So to address mental health services in the season we are in, we are saying that we need to map out the households where older persons and vulnerable families are. We've already started that in collaboration with other departments within the State Department. We have about 95% of the children in our charitable institutions who have already gone back to their families, and we're in the process of reintegrating. So we are in the process of identifying where are these families now, so that we can, strengthen families. So we need that data. We need to map out, and like I've said, we are with the additional 10 billion in the 4 counties. So that, and we're also using the Nyumba Kumi initiative, another government structure under the Ministry of Interior, so that we can be able to identify what are the new challenges now these children are facing, these families are facing. Pandemic, because of the other disasters we are seeing, like the floods, and then how do we provide services to them? And also, the other thing is also mapping out the elderly, as we all know that this is a high-risk group, and would want to capacity build and create awareness to older persons and the caregivers, and provide practical support such as screening. So we really want to map out the institutions that are working within communities for older persons. And like Stella said, a challenge of the practitioners who are offering services, it is important to take care and support the social workers, all of them that give special attention to the vulnerable groups in society. I was listening yesterday, and I heard that about 90,000 health workers have been infected by COVID, and it's important for the government to really look at ways to support and take care and provide all that is needed, so that these people, the service providers, are safe as they give their services. So the other one is to put in place measures to help the vulnerable groups maintain a healthy lifestyle. That cannot be overemphasized. when we talk, for example, about the elderly, right now they have to use technology, and this technology, we are talking about provision of the accessibility, to mobile phones, because now that is how they are getting their money, the cash transfer, how to use it. They have to be capacity build, and yes, making everything, making communication easy for the communities that you are serving and the families you are serving. The other one I can highlight here is include the unique needs and rights of older persons in any training and capacity building activities which are currently going on. We are talking about protecting them from violence, protecting them from abuse, and that is not just for older persons, even the children and the youths and the widows and the widowers. And then we have to strengthen the way we monitor and disperse the social funds right now, because these are vulnerable groups. And then we need to talk about, we need also to the other challenge is, which I can point here is, sorry, the Word document I'm straining to read, but it's okay, I can try. Raise, thank you. Basically, I want to summarize this by saying that let us maximize on the current structures that we have so that we can be able to serve the citizens of this country. Let us support each other. Let us collaborate more. Let us share more of information and use the existing structures that we have, so that we can be able to make sure that we survive the pandemic and we sustain our services even beyond the pandemic. Thank you so much for listening.
Great. Thank you so much, Jacinta, for that very informative and detailed presentation. I think we probably reached a point where we've oversaturated the audience with information, and likely they have a few burning questions. So what I'm happy to do is to invite Rosemary to help tackle some of the questions as we consolidate the presentation materials. Over to you, Rosemary.
Okay. Thank you, Kim, and thank you so much, Stella. Thank you, Jacinta. Those were very insightful presentations. I'm sure the participants will agree. We had some questions. There's one that was answered while Jacinta was presenting, but it had a follow-up question for you, Stella. Stella, are you there?
I'm here.
Okay, lovely. So the question was, there was a concern about the partnerships that organizations have with county. Moving forward to the Nairobi Metropolitan Services, do the partnerships transfer or what happens?
Thank you, Rosemary. It's just we have transferred back to national government and Nairobi Metropolitan Services, which is a department under the Ministry of Devolution. So we are not going back to be under the Ministry of Health.
Okay, we seem to have lost you a bit.
That we need. Oh, can you hear me now?
Yes, now we can hear you.
Unless there is something new now you want to annex, or maybe a very big that we need to sign afresh, but whatever we had with you, the functions, we have not changed anything. Even for the bigger, like the UNAIDS programs, nothing has changed. We are working as normal. Yeah.
Thank you, Stella. I believe that addresses that concern. Now, there was a question to you, Jacinta. Thank you for highlighting the work you're doing to protect the vulnerable people at this time. we know there are those who are more affected than others, and it's really great that there are arrangements to protect them. There's a question about the chronically ill being among the people who are listed as vulnerable. How do you register them, and what kind of services do they receive?
Okay, thank you for that question. I'd like to point out that these 5 categories, we have come up with them as one of the response after the head of state gave 10 billion to support the vulnerable. And so we were able to work. We are not working alone. We are working with the Ministry of Health. We are working with other stakeholders, and we have come up with a criteria which helps us to identify the vulnerable who are in this category of widows, critically ill, people with disability, and especially those who are presently not in the cash transfer program by the government. So there's a criteria in place to really enable us, together with the partners we are working with, to identify the very critical, chronically ill who are most vulnerable, so that they can be able to be enrolled to be receiving that 2,000 every 2 weeks. I hope I've answered the question.
So does that mean that the registration is ongoing? Is it a continuous registration, or has that already been done?
Yes, it is an ongoing process. Like I said, it has been piloted in the 4 counties, and it is ongoing. There's already a team, a coordinating team that has been put in place by the government, which is mandated to implement this.
Okay, thank you. And if I may weigh in on that myself, I know in our neighborhood we did have the chief and I believe that the Nyumbakumi overseers or something, they were going actually to households and asking if you have an elderly person who is chronically ill or disabled. So
yes,
possibly that's what was going on. Thank you, Jacinta. We are concerned also about street families. What is being done for the street families, especially those which are street families, especially those led by minors, where the family head is a minor?
Yeah, thank you for asking that question. The State Department for Social Protection has in place the Street Families Rehabilitation Trust Fund, and through this saga, we have been able to respond to the needs of street families during this time of the pandemic. We are doing our best to make sure the street families are supported. One, there are those that you're saying, like the child-headed, that we've already identified, and they have been moved to the CCIs, the charitable children's institutions, for support. And we are also supporting them in terms of course, through it's all collaboration. The Ministry of Interior, the chiefs, the community leaders, to identify where they are, and including the police, messages to the police to make sure that they don't harass these street children. And we are making sure that they are out of the streets by reintegrating them with their families, and again going ahead to identify where these families are, so that again they can be supported to keep the children in homes right now, and discourage them being in the streets. Those who have no families to care for them, we are making sure that they are put in our institutions for children. Thank you.
Okay, thank you, Jacinta. Very good insights there on what's being done for the street families. Now, a question for you, Stella. I know it refers to farming communities. I know in Nairobi, maybe there are not so many farming communities, but the question says, what is being done? Are they affected when it comes to their mental health, and what is being done for them? So are you in a position to give us some insight?
The farming community. Like farm. I know we have seen with the floods, and initially it was the locust and then the floods. But honestly, I think we have had so much on our plate with the informal settlement and the COVID. I would be lying if I said we have anything tailored or on the pipeline for or a program that we have thought about the farming community. Maybe basically because Nairobi is an urban area and the farmers we have are those ones who doing the garden, the small gardens. Yeah, we don't have a major problem for farmers.
Thank you, Stella. So I'll say, Sarah's maybe because we didn't have a representative from the Ministry of Health, they would have been best placed to say what's being done at the national level, because it is true, there's been a lot going on with the farming households, with the floods and the locusts, as Stella has mentioned. So yeah, maybe at another forum, somebody from the Ministry of Health would be best placed to answer. But back to you, Stella. There's a question here about deployment of mental health practitioners, certified mental health practitioners. For example, in the other professions, you have the nurses, you have the doctors. What about we know Jacinta talked about the lay counselors, and you also said about the need to provide low intensity therapies. But what about the deployment of certified mental health practitioners at the primary health level?
I would say, and those are some things you do and you feel proud of yourself. And I would say for the short time I've been in the unit, I've made several achievements to add those, because even for me, I'm a clinic officer by training, but branch over to psychology. And for me to have even been recognized to head the program, it was out of, like you're fighting for your space to do what you invested so much to go and do. And I can say that I have made progress. It may not seem much, but I've made progress. Like, for example, my recent achievement was in Pumwani, where we are starting a maternal mental health clinic. Initially, the nurses who have been supporting the mothers were just doing it in addition to their normal nursing duties. And you can imagine how busy Pumwani can be. So you're just called when there's a problem. But we had a meeting last week with the management, and we agreed that we're going to start a maternal mental health clinic at the outpatient that is going to run every day. And these nurses are going to be deployed to run those clinics. And for me, I slept happy that day because we were even given a room. However, the room is being used for isolation for now. So once COVID is done, we're going to have a fully fledged maternal mental health clinic. And for now, if we have partners who are willing to come and help us soup up the room, do branding for the room, because that one will be achievement. We have had other achievement where the other clinic that we run in Gara Health Center, we have a clinical psychologist who runs the clinic and a clinic officer mental health. They are purely doing that work out of a lot of lobbying, and she's not doing nursing duty, she's not doing clinic officer's duty, but basically performing those duties. And we are moving forward. We actually doing, we have rerouter that is on the pipeline, we have a nurse who is we are really pushing to have her doing the mental health. However, I have a lot of support, like for example, from the nursing director. But she asked me, always asked me, Stella, if they live and do that every day, who will do the duty? And our agreement, and I always talk to the staff and tell them, make sure you create a lot of workload on what you do, and you move slowly, because you would agree with me. We have a shortage of staff, and we have had agreement because we have a forum for all the mental health practitioners. And I tell them, work smart. Make sure that you're seeing mothers. If you like, for example, the psychiatric nurses in Pumwan, in Mama Lucy, we had a meeting with them, and I told them, work smart, start making yourself being felt. And when they wanted to move, I asked them, what have you done for the maternity mothers? What have you done at the ANC? Do you screen those mothers coming for maternal mental health? What have you done at the CCC? And it's only through your initiative that you can get deployed. So it's a two-pronged kind of an approach, where the nurses or the clinic officers or the psychologists who have qualified, they start showing their worth. And then eventually we get them doing their specialty day to day. But I would tell you with all certainty, it is not possible to withdraw all the nurses who have done psychology or psychiatric to start doing that in a go. But I can tell you, it's about being smart, and we are achieving it a step at a time. And God keep us and give us strength. In the next 2 years, we're going to have a stronger mental health workforce than we have today. And maybe we can have this discussion in another 1 year or 6 months, and we will be able to report on the progress. Thank you.
Thank you, Stella. Very insightful answer. I think we would like to have that conversation. I'm sure Kim is taking note. We definitely want to have that conversation in 6 months or a year to see what progress will have been made, to have more people who are trained in psychology, psychiatry practicing and not doing other duties. So there's a question.
Rosemary, Mary, just to add, as even as I'm pushing so hard in this, and I think maybe we have partners who have come in, like for example, I have really pushed to start the Pumwani clinic, but I would seek for, I always say we are professional beggars working in government anyway. We need files. We need to design that room to make it appealing to the mothers, because we need to do group therapy. Looking at the mothers are there maybe for a week, so it may be hard to reach every mother on one-on-one, but we are looking into utilizing group sessions. So we would call upon the partners who are on board, and even the partners to your partners and the partners who would come on board and provide for us with simple things like support for printing out tools, for screening, support for having files, because we want to have records, support for having record books. Can we have a big black books where the counselors are able to record what they have seen, and even plastic chairs for them to be able to carry on the group therapy, and maybe a nice curtain and nice charts or even infographics on maternal mental health, so that even going forward, the other facilities are able to learn from Pumwani what they have done with their maternal mental health, and we can even challenge the government or the county that we have now 2 psychologists seeing 100 mothers. It is not possible. Can you post for us more? So I think that's the approach. As much as I'm working so hard, I also need the support of the partners to augment what we are doing at the county level.
Thank you, Stella. That has been noted, and we will do our bit. We will try. I'm sure Kim and other partners who are part of this webinar will try, as well as the supporters that we have on board. I know Kevin from CBM is listening, so we will all put our heads together and see what can be done to support you, because it's a very excellent initiative, especially being Pumwani and what we hear about Pumwani. It will be very nice to have mental health support services there. So there's another 2 questions which are similar about partnership with the media on behavior change communication. I believe that can be addressed by both you, Stella, and also Jacinta. What are you doing with the media to get the information out there? There's a concern that people don't have the information they need. For example, in Old Town and Isili, could there be more information going out there to help the communities cope, and even the school children to know how to handle this whole situation?
I think you've just asked if, and we just had a meeting yesterday. Actually, we left office past 6 with one of the USA partners, and that was one of the components. Yes, we are doing we're small, in our own small ways. We have our health promotion officers who have been coming out very strongly to, engage the media. However, one of the strong points we asked is looking at COVID is a national pandemic. We were asking ourselves, how do we get, and maybe this is a question I would throw to all the panelists here. When we are being given that brief every day at around this 4:03, and you're told how many people have turned positive, where the quarantine sites are, our ask was, and we were brainstorming and asking ourselves, what about having in the same briefing people being told where to seek psychosocial support, people being told of the helpline? Everyone knows about the helpline to call when they feel like they have COVID-ish, But in the same breath, we were hoping that they would be told where they can seek support. They will be told what to do when you feel anxious. They will be told what to do when you've been tested and you're waiting for results. So I think as much as we are doing it at the county level, and I believe with this partnership, we are really looking forward of having, and that was one was also for us, having even posters. You would agree with me that we have posters all over about COVID, but we have almost no or very little posters on mental health during COVID. So I think it's a discussion that we need to have, and more so, the influencers to the national government to bring the aspect of mental health and psychosocial support on the top tier as they're giving other information. Thank you.
That's noted, very true. Jacinta, did you have any other insights on that, especially for the children and other vulnerable groups, how we reach them?
Yes, thank you, Rosemary, for the question. I would say that we are in partnership with media in terms of creating the awareness of this pandemic. Just this week, even yesterday, our CS was on NTV on this National Leaders Forum, highlighting issues to do with safety at the workplace, and also awareness messages to families on how they need to handle the situation they are in and keep safe. So we are there communicating to children through the media, national TV, and in the National Family Promotion and Protection Policy. Media and technology is one of our thematic areas where we are talking about coming up with pro-family programs, what we are already doing, and also making the media play its role in terms of controlling, in terms of promoting parental control and appropriate use of technology by family members. So those are the kind of messages that we are partnering with media to communicate. Next week on Friday will be the International Day of the Family, and we have the Fourth Estate on board in our National Steering Committee to partner with them in terms of coming up with key messages for families, what we can communicate to families during this season of the pandemic. Best way to communicate the pandemic and how families should stay safe. So we are at it. They are part of us, and we're working closely with them.
Excellent, very good.
I think I can also add at the county level, we have our own field officers who have actually featured in the, in the radio stations, the vernacular radio stations, trying to communicate these messages to the communities on the pandemic, the dangers, and keeping safe, and eating well and taking good care of their children. So we are doing our social work very well at the grassroots, and even at the headquarters in terms of working with the media. Thank you.
Thank you, Jacinta. Thank you, Stella. I think the partners who are in on the call, instead of developing parallel materials, these are opportunities to look at speaking with Stella, speaking with Jacinta, and doing communication, synergized communication, and using similar channels to reach more people. I know we are running out of time, Kim, but I see like 2 questions. I think the questions on the Q&A are already answered. I know there was one question about Mandera. I don't know who feels between you, Stella. I see the question goes to you, Stella, about handling the situation with the mental health providers. Let me see this about Mandera. Certified mental health workers, community-based mental health workers that like sorry, I've seen that. It's a question that you already answered about having people trained as mental health practitioners to do their job as practitioners, not to do other roles. Sorry about that. So one other question, Stella, about I know you in the past you have assisted us to do events and to do for NGOs to do events in the county, and you've gotten us permits or waivers on the licenses to continue with such activities. So there's a question, will that go on under the NMS?
I would think nothing much has changed because again, it's still under the revenue collection, and if it's a health, however, because I had not thought of it before, because I think after we moved in the process of transition and Corona came So I think what I would say for this specific one, the specific partner who would want to carry out an event would maybe get in touch with me. And we discuss, as you know, Rosalind, we always have to see if it's something that is going to be of benefit for us as NMS. And then I would pick it up for that specific issue. Because if it was the previous regime, I would say definitely yes, you come, we discuss, and I would push. But with this one, I don't want to say it's a yes or it's a no. Let the partner get in touch. We discuss the occasion or the function or the activity. Then I pick it up from there. But definitely, if it's something that is for our Nairobians under our own jurisdiction, I would take it personally and run with it and try as much as we can to get the waivers.
Okay, thank you. So one final question is about the indicators we use to determine whether a program, project, or intervention has worked. Are there any direct or indirect pointers from Mary Odongo? Do you want to comment on that, the indicators that we will use?
Hello. Yes.
Sorry,
is it indicate? Is it?
Mm.
There's someone whose mic is on. Is it indicators that we will use or indicators that we use? Maybe for that clarity.
I think it's what you use, not what you will use.
You remember one of the challenges I said is that we have very poor reporting tools, or not, let me not use the word poor, but say that our data is not well captured. And how the system works is that you develop indicators that are again captured in the data. So with that, you're able to analyze the data. So I would say we are at a very gray area where, I mean, we cannot just sit down and not offer interventions because we don't have very indicators. We have developed some in terms of one of them that I would remember offered is the number of people who are coming to seek mental health services at the primary health care, which is as a result of involving with the community strategy. That's an indicator to show that our community engagement is bearing fruit, that more people are coming to seek services. And then the second number is the number of people who are accessing psychotropics, being an indicator of accessibility. So we are still struggling to have them very consolidated so that we have for these, because we develop for every financial year. So I think there's also another one that we are dealing for currently in this financial year. However, that one will be it will crystallize when we have our indicators or our data being captured in the DHIS.
Oh, that would be excellent. If you had the DHIS capturing mental health data, that would be perfect. So I don't know, did you have a comment on the same, Jacinta, about indicators?
Sorry, Rosemary, ask the question again, please.
Sorry, Jacinta, the question is asking about the indicators that you use to determine whether a project or program or intervention has worked.
I would answer by saying our monitoring system that is in place helps us just to see how far we are with the services we are giving. For example, the cash transfer to the vulnerable, to the older persons, through the social development officers, we are able to monitor how they are doing, who has exited from the program, either because of death or something like that. And so we are able to be informed on when and how to upscale and add more people into the program. And also, basically, the monitoring that we do for all our programs is what assists us really to measure how well we are doing.
Okay. Thank you. Maybe if you had some links that you could share so that people can access further information, maybe this could be shared with Kim and we could forward to the participants. But I believe we've answered the question, so I'll take it back to you, Kim, please. Thank you so much, Jacinta. Thank you, Stella.
Thank you, Jacinta. Thank you, Stella. Thank you, Rosemary, for moderating that Q&A session. I think there was one other question that I saw on whether or not the materials will be provided. Yes, they certainly will. So rest assured you will get access to those. I did see a few hands up, so not sure if the questions have been addressed, but let me at least give folks a chance to ask any questions, especially if their hands are still up. So let me hand it over quickly to Ibrahim. Ibrahim, go ahead. All right, I guess I can't hear you, Ibrahim, but if you're there, please feel free to speak. Meanwhile, any other last minute questions? I don't think anything's coming up. But I think it's been a really good conversation. I really enjoyed learning, listening, and participating in our deliberation so far. Thank you so much for the engagement. I'd be remiss if I didn't allow Alex to sort of say something, and then feel free to wrap it up for us. But meanwhile, if anyone has one last burning question, happy to provide for that, and then we'll just end. Go ahead, Alex.
Thank you, Kim. Just wanted to say thank you to everyone for participating and also for attending. I think this is a really important conversation for us all to have. I'm working more from the private sector, and we've heard a lot from the public sector here. And I see on the attendees list we have some people like Bright Shitemi, for example, from Mental 360. There's a lot of people working on this problem from a number of different angles, and it's important for us all to get together and have these discussions. So thank you all for attending. And yeah, please feel free to reach out to any of the panelists. I think Kim is going to share contact details for all of us. So if anyone has any questions, please feel free to follow up.
Great. And I think with that, we are happy to end. Thank you for everyone's attention and eagerness to participate. It's really been great to hear all of your perspectives. And if you did not get a chance to ask a question, or if something comes up following this, please feel free to reach out to us, and we shall circulate the materials so then you have access to those. All right. So unless there's anything, I'm happy for us to end it here. Wishing all of you a lovely rest of your afternoon. Be safe, take care, and we'll connect soon.
Yeah, thank you.
Thank you too. Bye, everybody.
Bye.